University of Lagos, and then he's been with us and really completed a cool project. I think it's an example of something that if you're willing to be a little bit flexible and meet the challenges that you're faced with, you can still pull out something that's really actually important. I think you'll find that the research that he's conducted has some important implications. And I just want to let you know after he leaves us here, he's going to get married on February 15th. So congratulations. And then he's going to do a 1-month, consultancy in Kenya. And then he's going to go on to practice family medicine in London. Family medicine with a public health perspective. Can you imagine how this would be? So without further ado, let's welcome Phil.
Good afternoon, everybody. Good afternoon, Dr. Hunting.
So actually, you can
Dr.
look
Balin's
to
on
that
there.
camera right there.
Okay, good afternoon, Dr. Hunting. Dr. Balin, good afternoon, and I don't know who's the third person.
You can just wait.
Oh,
And you go first.
I'll be presenting my CE topic, which is a comparative analysis of TB contact investigation in the District of Columbia, Maryland, and Virginia.
To the right.
So my project started in 2012 when I was an intern at the clinical center at the NIH with Dr. Balin. She is my preceptor, and I worked with her at the clinical center. She was working on a TB tuberculosis project at the NIH, and she told me the challenges that she was facing during their TB contact investigation, and I felt that this is going to be a very interesting CE topic. So I asked her if I could come on board, and she said sure. And that's where it all started. Tuberculosis is caused by Mycobacterium tuberculosis, and it primarily affects the lungs, the kidneys, the adrenals, and the spine. And TB could be spread from person to person by airdrops in the droplets, and if it's not properly treated, it can be fatal. Tuberculosis can be divided into two: latent TB and the active form of TB. The latent TB the individual with the latent TB does not feel sick, and they don't have any symptoms of the disease, because the immune system is keeping the MTB, that is the Mycobacterium tuberculosis, in check. But however, if there's any form of compromise, anything that compromises the immune system, then the TB bacterium will now overwhelm the system. That's when the person now presents with the active form of the disease. And it multiplies rapidly in the body and can spread to other parts of the body. And the signs and symptoms of tuberculosis are cough, fatigue, weight loss, night sweat, chills, and fever. And the modes of transmission of pulmonary TB, as we all know, I'm sure many of us here would know that TB is spread by coughing, speaking, singing, and sneezing. The test that we use for TB is the tuberculin skin test. That is the most popular test used because it's been around for about 100 years. It's cheap. And the other forms of testing are the quantiferon gold, the T-spot, the gene expert, sputum for acid-fast bacilli, chest X-ray, and computerized tomography of the scan of the chest. And why are we concerned about TB? There's been an emergence of multi-drug resistant TB, which has been a major threat to public health. And the Centers for Disease Control and Prevention, the CDC, reported that 1/3 of the world's population are affected with Mycobacterium tuberculosis. In 2011, approximately 9 million people worldwide developed illness as a result of MTB. Between 2000 and 2004, some researchers conducted a series of surveys in 48 countries for MTB isolates that were resistant to the second-line drugs for TB, for treating TB. And this survey showed extensively drug-resistant TB, which is multi-drug resistant TB with further resistance to 2 or more classes of the second line drugs. There are 3 lines of management, that's treatment for TB, the first line, second, and the third line. So the first line drugs are rifampin, isoniazid, rifampicol, and ethambutol, but there's a further second line drug that is used when there's resistance, and those are injectables, and they are very toxic. They could cause renal failure and deafness. So the CDC also reported a large hospital outbreak of highly drug-resistant TB in New York in 1991 among 8 patients. A group of scientists also conducted another study, a study which described the epidemiology of the extensively drug-resistant TB in the US. And the study showed a reduction in the cases of XDR TB since '93, but however, there has been reported cases every year, which is of great concern. Then I would like to introduce 2 terminologies to you, the case and exposure definition. Who is a case definition when it comes to TB? A case definition is a person that meets the clinical criteria and laboratory criteria for TB. An exposure definition is an individual's exposure time period with someone with suspected or active TB. And the CDC has an exposure definition, which is a guide for screening for TB, and it's an 8 hours of cumulative exposure to someone with suspected or active TB. And when a diagnosis of TB has been established, it's imperative to conduct a TB contact investigation in order to contain the spread of the disease. And the criteria are divided into 2, the clinical criteria and the laboratory criteria. The clinical criteria, the first one is a positive TST, that's the skin test, or IGRAS, that's interferon gamma release assay for Mycobacterium tuberculosis. And signs and symptoms consistent with TB, such as abnormal chest X-ray and other chest imaging studies, and evidence of active TB disease in the individual. And treatments with 2 or more anti-TB drugs, and a completed diagnostic evaluation of that patient. And the laboratory criteria are the isolation of MTB from clinical specimens such as the sputum or the GERD, and nucleic acid amplification test demonstrating MTB from clinical specimen, or a clinical specimen demonstrating acid-fast bacilli when a culture cannot be obtained or gives a false negative result. Then this schematic is the CDC's concentric circle approach to conducting a TB contact investigation. And this helps in prioritizing contacts of the person, the individual that has the TB disease itself. So looking at the schematic from 1 to 4, that depicts the level of prioritizing the contacts. Number 1 is the index case, that's the original person with the TB disease. Then the households, people living around the TB patient, people living in congregated setting, for example, correctional facilities, nursing home, and hostels. Then institutional settings, such as in the workplace, such as the hospitals and schools, and leisure parks, clubs, movie, where the person goes to. So you move from in to outward, the circle. So the closer you are to the index case, that makes you a higher priority when it comes to contact investigation. At times you do a contact investigation on 2 and 3 high priority contacts, or medium, you stop at that because of funding. Then the objectives of the survey were to compare the case and exposure definitions at 6 county health departments and 15 hospitals in the DMV area, Districts of Columbia, Maryland, and Virginia. and to confirm if these county health departments and hospitals follow the CDC contact investigation guidelines, and to also identify if there was failure to follow up during TB contact investigations and what actions were taken, and to provide recommendations to the CDC for TB contact investigation in hospital settings. This is the map of the survey area, and the NIH is somewhere here in Montgomery County. Then the methods that I used for the survey, I started with a Google search to inform the contact information of the counties that were in the survey, the 6 counties in the survey contiguous to the NIH campus in Bethesda. Then when I moved on to do my survey in the hospital, I conducted my search with the Yellow Pages, Town Locator, Hospital Guide USA, and USA Hospital Information. And a huge list of hospitals popped up, so I had to narrow down my search to just teaching hospitals, community hospitals, and children's hospitals. Then I began my survey with phone calls. I made phone calls out to the counties to schedule an appointment to come in for an interview. And apart from the phone calls, I did personal interviews at the counties and some of the hospitals, and I also sent out emails. But the phone call, some hospitals declined to phone call because of confidentiality issue. Then this is a list of the county health departments that were in the survey. I carried 6 counties health departments, and this table shows the hospitals, the counties that the hospitals in the survey were located, the numbers that I contacted, and the number of hospitals that completed the questionnaire, and the number of hospitals that I'm still awaiting their questionnaires, and the non-responders. This graph shows the hospitals exposure definition, and while we can all see that there's variation across the board in all hospitals, which is contrary to what I found at the county health departments. All the 6 counties that I surveyed followed the CDC's 8 hours cumulative exposure over 1 week. But in the hospitals, there's variation across. As you can see, some hospitals just went ahead to screen anyone that came in direct contact with a suspected or a TB patient, regardless of the time interval. And we can see other hospitals, how it varied across the board. Then the actions that were taken for failure to follow up, because failure to follow up was common in the hospital setting, and the actions the hospitals took on employees that failed to show up for follow-up during the contact investigation. Because during a TB investigation, once the index patient has been identified, all the contacts around that person or everywhere the index case person has been, you go there and you conduct a screening of everyone that came in contact with the person. So they come in for the first test, screening test, you ask them to come back within 8 to 10 weeks, but unfortunately people don't show up. They disappear after the first screening, which is a big problem, in the result of any contact investigation. And as you can see, most of the hospitals, they did nothing to their employees that did not comply with follow-up. Then my results, all the counties followed the CDC's TB contact investigation guidelines without no variations at all. But in the hospitals, there were variations from 5 minutes to 8 hours, and direct contact with face-to-face with the suspected or TB patient. And most of the hospitals, they came up with their justifications for their different exposure definitions, which range from some said we just wanted to cover universal coverage for all our workers, visitors, and patients. While, to my surprise, one of the hospitals said they don't have any justification for the 2 hours they use, which I found very interesting. And there was failure to follow up was common in all the counties that I surveyed and all the hospitals. However, one hospital reported 100% follow-up during TB contact investigation. And I confirmed that with the director of infection control because I interviewed him in person. And he also contacted the nurse, the infection control nurse, and she also corroborated what the director said. Then the strengths of my study were I had the opportunity to examine the reports and standard operating procedures in the county health department and the hospital, which gave me an insight into the variations in the exposure definitions among hospitals as compared to county health departments. And one of my constraints were financial constraints. This survey was self-funded. And I had difficulties in contacting some of the program coordinators at the health department, and it took me 4 months to contact one program coordinator at one health department. So that delayed the turnaround time for the questionnaire. And I also, there was low participation rate in the survey among the hospitals compared to the 6 counties that they all participated fully in the survey. And my conclusion is that the study revealed the variation in exposure definition in the hospital setting, and this variation in exposure may influence TB investigations and control across the DMV area. And harmonization reported in the counties during their TB contact investigation maybe was likely due to clear standards the CDC set down, because they followed the standards of the CDC for exposure definition. And the high failure to follow up rates for TB contact investigation may affect the outcome of the results of any screening exercise. My recommendation is that the standardized time of exposure definition should be included in the CDC TB contact investigation guidelines for hospitals. Because the CDC guidelines for TB investigation in the hospitals, they just said that any healthcare worker that is exposed to a suspected or TB patient should be included in the TB screening. So there was no specific time given. Maybe that's why they just came up with different exposure definition. And the similarities in practice and protocols across the board is very essential when you're carrying out such an investigation, so that everything will be standard across the board. And I also recommend the education of employees on TB in order to improve their follow-up rates, because if they know the consequences of untreated TB, not properly treated TB, multi-drug resistance, and ultimately it could lead to death. Maybe that might change the attitudes of healthcare workers. But to my surprise, some of those that were non-compliant were physicians and nurses in the hospitals, which was very surprising to me. So what the take-home message I want to pass across here is that the standardization of the exposure definition in a TB contact investigation cannot be overemphasized, because that will most likely, alter or influence the results negatively or positively of a TB investigation, and that will also help in further studies and other treatment modalities for the disease. I would like to say a very big thank you to Dr. Lance Price for his mentorship. He's been very supportive.